Welcome everybody to National Single Payer. My name is Judy Albert. I'm one of the steering committee members for National Single Payer. We are a national grassroots organization that organizes locally in the struggle for national single payer healthcare. We're united by the common principles that healthcare is a human right, must be free from corporate profit, and must be achieved through national legislation. If you would like to support our work, please donate to our organization. We will periodically drop a link in the chat that you can click and donate throughout tonight's event. Our guest speakers will speak for about 45 minutes, after which I will ask the questions posted in the Q&A. Please be advised that I will try to get to as many of the questions as possible, but most of the time I'm not able to get to all of them during these webinars. And now what I would like to do is read a statement that Anna Malinow, another one of our steering committee leaders, has put together. People who have been to our webinars before know that Anna Malinow is usually leading us. Unfortunately, because of the quick change that we made in our last month's webinar to accommodate Sarah Nelson's schedule, she was unable to be here tonight due to a planned set of travels. And so I would like to just read something that she put together before she had to leave by way of history. In May of 2021, in the throes of the pandemic, Kay Tillow and I published Medicare for None, a response to the State-Based Universal Healthcare Act of 2021. We wrote, quote, "The COVID-19 pandemic has laid bare the inequities, inefficiencies, and ineffectiveness of our healthcare system. If there was ever a time for healthcare reform, this is it. But some healthcare activists and their progressive allies, suffering from the frustration and delusion brought on by the refusal of President Joe Biden and Congress to consider structural reform, have accepted this defeat and turned to state-based reform, jeopardizing Medicare across the country. We concluded, healthcare is a national responsibility. To palm it off to states is a step backwards. The U.S. doesn't need to dismantle Medicare. It needs to improve and expand it to every person. The country must replace its broken, fragmented, profit-driven, racist system with a universal, affordable, comprehensive, evidence-based, equitable, single-payer Medicare for all, not Medicare for none. Every resident of every state deserves this. This is something on which we can all agree." And here we are again, exactly 3 years later, no closer to a state-based bill and far away from a national bill, despite the ever-growing popularity of improved and expanded Medicare for all and a historic number of congressional co-sponsors of the National Medicare for All bill. We are here tonight to try to understand why we can't seem to budge. Why, in the face of massive support for Medicare for All and the failure of the US's for-profit healthcare system, when the inevitable fall of the medical industrial complex can be predicted, if not with precision, with certainty, we are divided on how to move forward. Those of us in the state-based camp believe in the certainty that once one state achieves single payer, other states will follow, and eventually the federal government will have no other option than to follow suit. For this reason, states with the highest probability should dedicate their activist time, effort, resources, and money to a state single payer bill. Those of us in the national single payer camp believe that states cannot achieve single payer, that not all strategies are created equally, nor are they all harm-free, and that the pursuit of state-based single payer can actually hamper the possibility of achieving national single payer. The webinar will likely not convince those who are firmly in one camp to switch to the other camp tonight, but we hope to make the case for the many who are in neither camp that together we have a better chance of achieving national single payer than atomized into 50 different groups rooting for 50 different states. That collectively, our voice for single payer will be stronger and clearer and invincible, which is the ultimate goal of every single payer activist, no matter which camp you are in. I hope you enjoyed the webinar. And now I would like to pass the honors to Ed Gristar, who will provide the introductions of our speakers tonight.
Okay. Thank you, Judy, and welcome to everyone for attend tonight's meeting. We think we have a necessary and informative discussion that's necessary to shape the agenda as we move forward in this time of all types of crises in this country. And so it's my pleasure to introduce two women this evening, both of which who I have known for many years. Kay Tillow was born in Paducah, Kentucky, worked in the Southern Civil Rights Movement in the 1960s, and she spent her early career working for healthcare and nurses unions on organizing collective bargaining, and was responsible for organizing over 600 unions to endorse H.R. 676, John Conyers Medicare for All Act. I knew Kay Tillow in Pittsburgh, and I think when I first met them, her and her husband, it was around 1978 when we had the pleasure of having Ron Dellums come to the University of Pittsburgh to talk about a national health service bill, and that was in 1978. So Kay Tillow has spent literally her whole life in this struggle, and she should be commended for that. Currently, she is chair of the Kentuckians for Single Payer Healthcare and coordinator for the All Unions Committee for Single Payer Healthcare. She is also on the National Single Payer Steering Committee. Our second speaker is Dr. Claire Cohen, African-American child and adolescent psychiatrist, and since 1984, she has practiced in community health clinics, partial hospitals, school-based settings, and currently an inpatient hospital. I've known Claire also for many years since she is active in Pittsburgh, where I am from. She's also on the steering committee of the Western PA Coalition for Single Payer Healthcare, working to stop the school to prison pipeline in the Pittsburgh public schools. She's a founding member of the Pittsburgh Green New Deal. She's also an at-large member of the American Friends Service Committee. So with that, I would like now to welcome both of the speakers and turn it over to Kay Tillow.
Thank you, Ed. I appreciate that. And I want to say welcome to everybody who took the time to come out to this. I think it's a really important discussion. You know, many of us have been at this for a very long time. I was a part of the group in Louisville that wrapped red tape around the Humana building in the early 90s when we had the caravan across the state to work for single payer. And at that time, we in Kentucky also introduced a state single payer bill. Let me just acknowledge that the work that people do makes a difference. And let's look at what we agree on first. And that is that we have common ground. We've been working these last few years against the privatization of Medicare. We see Medicare as precious and to be preserved. We did battle against the direct contracting entities where the Innovation Center was turning, and still is, turning over Medicare, traditional Medicare, to for-profit entities and venture capital without the consent of those who were in those programs. As we raised Cain about that, they changed the name to ACO REACH, introducing the idea that somehow it would bring equity, but basically keeping the same privatization. And we agree on that we need to end that. And we agree on a campaign that is vibrant now to end Medicare Advantage, to go after the exposure of what the private for-profit insurance industry does to us and how they are taking the money from the Medicare Trust Fund from 80 to 140 billion annually, and the harm that that is doing both to the trust fund and to the patients. So we agree on that, and we're battling to stop the privatization of Medicare. I think that we also agree that the end goal is a national Medicare for all, an improved Medicare for all with the profits gone, or a national health service. I think many of us think that that is a legitimate goal as well. What we disagree on is giving the Medicare money and the other federal money to the states for an experiment. And what prompted the article that I wrote for Common Dreams, which is, I think it was April 1, and It was precipitated by my finding out that Senator Markey was planning to introduce the state-based Universal Health Care Act in the Senate. I had been aware that there is a bill in the House of the same name, currently sponsored by Ro Khanna, but it seemed that it wasn't going anywhere and no one paid any attention to it. But when I saw that there was an effort to move it into the Senate and to move it forward, I thought it was time for those of us who have concerns about it to say why. And I think, we have a responsibility to say what we think and to have an honest discussion. If we think something is really damaging to the movement, we should say it and we should raise it with our colleagues and try to work it through. So that's why I wrote the piece and why I'm going to talk about it tonight. The legislation, while it's been around for a while, if it gets introduced in the Senate, and I haven't been able to figure out, I haven't seen that it has been, but I know that Markey announced that he was going to introduce it. So let me just talk briefly about what that law does. And it seems to me that the Markey legislation and the Ro Khanna legislation are identical. The law directs the Secretary of Health and Human Services to grant waivers to the states for state experiments in providing universal health care. And that gives the money over to the state, and that means the Medicare money, Medicaid money, the federal employee health benefits money, and the TRICARE, which is the military money, to the states with very, very meager commitments as to what is to be done with that. The minimal requirement for the state under that law is that they should cover 95% of the people with health care within 5 years, and that the state should grant to the beneficiaries of Medicare and the other programs benefits as good as they now have. That's basically it. What it does not say, this legislation, I think it's the state-based Universal Health Care Act. It does not say that the experiment at the state level must be a single payer plan. It simply says whatever plan is approved by the head of Health and Human Services can go forward. So there's nothing to stop the money from Medicare going to states who then set up a market-based plan, a public option plan, a plan with Cigna, Humana, and Aetna, and United Healthcare involved in the structure of the state's plan. So any insurance company or profit-making entity could be a part of that plan according to the discretion of the state. And we would then be dependent on the discretion and the politics of the Secretary of Health and Human Services to turn that money over. It would be taken out of the hands of the Congress. So those, I think, are two of the very, very important points, is that the law could serve as a means of further privatizing Medicare, because it passes the Medicare money on to the state, who can put it in the hands of whoever they choose to place it in. And it means that Congress is no longer in control of the Medicare money, that this process of breaking up Medicare and handing it out to the states will take place depending on the politics and discretion of the Secretary of HHS, with Congress having no say over it at all. And I would just like to just recall to people here who've been involved in trying to end the direct contracting and the ACO REACH. That's exactly what happens with the Center for Medicare and Medicaid Innovation. They've been handing over the money in these models of experimentation, and all of that has ended up in a privatization scheme that is continuing to this day. So we need to protect Medicare from what would be a breakup and virtually a destruction of the program. I'd like to recall for us, I think many of you know about it, that Medicare has a very proud history, not just in bringing healthcare to the elderly, which it did, and the disabled, but at the initiation of Medicare, it became the basis for the desegregation of the hospitals in our country, the southern ones and northern ones as well. And it's a beautiful story of what can be done with federal legislation in conjunction with a movement, so that written into the Medicare law was a requirement that a hospital had to be certified in compliance with civil rights law in order to be able to get the Medicare money. And that federal hold over the Medicare money and a grassroots movement that was checking out all the hospitals and making sure and reporting them when they weren't in compliance made it possible that this federal program brought about a real transformation towards justice in desegregating the nation's hospitals. That would not happen if a state-based plan had been put into effect. And in fact, we know that state-based plans often do bad things. State-based program implementation has taken us backwards in terms of voting rights and in terms of reproductive rights. And we're not getting away from it. And one state doing good doesn't mean that another state's not going to do bad. So handing over to the states can lead us in the wrong direction, and it certainly would with healthcare. Progress in one state is really no guarantee of progress in the others. And what I wrote was that in Texas, a single mother with one child is not eligible for Medicaid if her income is above $272 a month. This state-by-state implementation of a program since 1965 has not become equal, because the discretion of the states to decide eligibility, to decide levels of benefits, has kept it unequal and unjust. I'd like to talk about workers' compensation and unemployment compensation, because those are two other programs where it's federal and state, but with the states having a great deal of power over the decision-making and the taxing. And what we've seen with workers' comp, and I've seen it both in Pennsylvania and I saw it in Kentucky, where there's a fairly decent workers' comp program. And then there is a corporation who says, we will locate in your state if you change the tax policy and lower the workers' compensation rate. And under the pressure to gain those jobs, we've seen the states comply. And I saw it with Democrats and Republicans in Kentucky, because they wanted to be able to get the location of work for the state. They lowered the tax rate and they corrupted the workers' compensation. I watched the hearings where wounded workers walked with their crutches up to testify, and we couldn't stop it because it was a race to the bottom in order to try to get those jobs from another state. And we don't need that kind of competition. We don't want healthcare to become an area in which we are racing to the bottom to lower the tax rate in the state in order to get the jobs. I believe that removing healthcare as a federal responsibility would be a grave error. How in the world are we ever going to get it back on a federal level if we turn it over to the states? And no one has answered that question. Once the money goes out to the states, there's going to be set up a chain in which people in that state want that money. It provides certain jobs and structure, et cetera. How will we get it back? We should not turn it over to the states. We need to keep it as a federal responsibility, and Medicare is our best program. I want to talk just briefly about the very low bar on the law. CMS has not been able to make Medicare Advantage comply with the law. Supposedly, Medicare Advantage must provide the benefits that are in traditional Medicare Parts A and B. That's a part of the law. Does it happen? No. We know that it doesn't. CMS either is unable or unwilling or incapable of enforcing that law. So how will we get an enforcement in the state by CMS that assures that the people who formerly got traditional Medicare, who are now in the state plan, will have benefits equal to what they had before? In fact, it's an impossibility for the state to provide benefits equal. For how is the state going to contract with all of the hospitals, all of the physicians that accept traditional Medicare to accept their state plan, which they have now put the people in Medicare in? So there's no way that the benefits are going to be equal to what people have now. In addition, this requirement that the state cover 95% of the people with insurance, that's a really low bar. Already 10 states have 5% or less of people who are uninsured. So there really is no progress. You're not forcing any advancement with such a low bar as that. I'd like to speak briefly about Saskatchewan, because everybody talks about Saskatchewan. As all of you know, that's the province in Canada that first passed a single-payer legislation, and that is used by those who say we have to go state by state. They say Saskatchewan went, and then other provinces, and then they got the national. Well, the difference is, and it's a really important difference, is that Canada didn't have any federal healthcare programs that had to be broken up and handed over to the states in order to do it within a province. They didn't have it. That's our situation now. We have to go backward and break up the federal Medicare program that is so vital in order to be able to turn that over to the states, and it's too big a price. I think one of the most important points to make is that those who say we have to do a state model, it's necessary before we can move further ahead. And I think that's a false reasoning about what has been the barrier to moving forward. It's not for lack of models. Models have been implemented with single payer and a national health service all across the globe. And anyone who studies knows that. So it's not that we have to do models to find out what will work. We know what works. It's been proven over and over and over again. We know what works. The barrier is not the lack of a model. The barrier is an industry that has captured the media, the politicians, academia, the research institutions, etc. But in spite of that, they have not captured the public opinion, and we have majority opinion. So it's not a matter of proving what works. It's a matter of organizing the power to put that on the nation's agenda. And we can do that a lot better if we do that together as a nation rather than one state trying to battle off the power of an entire healthcare industry that has a lot of money. Let me give a couple of more issues. I think that when we hear it introduced to say, you know, we're talking about turning over this money to the states, it's always preceded by a statement that says, well, look at the Congress. We can't pass Medicare for all now. With this Congress, so we can't do it there, so let's go do this. And it comes out of despair of putting what needs to be done on the nation's table. And I think that that's not a place to proceed from. We don't change the policy because we're confronting opposition. We figure out how to organize to take on that opposition in a way that we can win. And we should not start from a position of despair. Once you say it can't be done, you let the whole Congress off the hook. Nobody has to do it if you start from a position that says it can't be done. And we have to start from a position that says, look, we don't have any other alternative. Don Berwick just announced we're 69th in the world at the recent hearing in Massachusetts, that our health system is 69th in effectiveness at delivering healthcare. So we don't have anywhere else to go, and nothing short of national single payer or a national health service will bring us the system that will get us out of this jam, and we have to find a way to take it on. And I'm just going to close with my experience in the civil rights movement. And I was fortunate enough to be of an age where I could go to Mississippi and see what was going on. And I was amazed and inspired and sent into a lifelong pursuit of justice by what I saw from the people in that movement who never said it can't be done, but who spoke from a position of hope and belief, and if it was right, then it had to be made so. And I remember the same thing being said when I attended a union conference in the early 90s with the Paul Wellstone, who was the senator from Minnesota. And he was very, very small guy, quite short. And he stood up in front of the group and he said, "Don't tell me it can't be done. If single payer is what you need to do to bring care to your neighbor and your grandmother and your child and your community, if single payer is good for the nation, then we have to make it be done." And he stood very tall as he proclaimed that and jumped up and down in front of the group. And that kind of inspiration is what we need now. And I'm turning this discussion over to Dr. Claire Cohen from Kentucky to Pittsburgh.
Okay, all right. Thank you, Kay. So I want to focus on the fight for single-payer healthcare in the context of the racist socio-political culture of the United States and how that should inform our difficult struggle. While yes, there's racism at every level of our society, The historical political structure and tradition of our country has been such that racist social policies have been most effectively and persistently implemented on the state's level, states' rights, from slavery to segregation, to voting laws, to welfare policy, to criminal justice laws and policy, etc. Yes, there have been states that have piloted progressive programs and policies, but these have not been the states with the greatest proportion of Black people. Historically, there are states in the Black Belt South that have tended to have reactionary governments and in which the ruling classes have been successful in creating a culture in which the majority of citizens, primarily poor and working class whites, have bought the idea that it is not in their interest to have an equitable society with universal social coverage of any type of social safety net, including health care. That there are two classes of people, the deserving and the undeserving. This is why these states have poorer workers' compensation, less workers' rights, more restricted voting rights, inadequate welfare benefit coverage for the poor, even women and children, more punitive juvenile justice laws and policies, and harsher criminal justice laws and policies. This is why there are 9 to 10 states that still have not implemented expanded Medicare and will not do so unless forced. Mississippi, Alabama, Georgia, and Arkansas, 4 of the 12 Black Belt states, have the least generous welfare benefits for the poor. States with the most generous policies include Vermont, New York, Minnesota, California, and Alaska. The Black Belt South states, just in case people aren't aware what they are Alabama, Arkansas, Florida, Georgia, Louisiana, Mississippi, South Carolina, North Carolina, Tennessee, Texas, Virginia, and Maryland. With the exception of Maryland, these states have traditionally been states in which there is a culture of identifying groups of people as being deserving versus non-deserving, largely based on race. The upper classes in these states have actually seen it as in their interest to keep wages and benefits and social benefits down as a part of their strategy for accumulating wealth and sabotaging class struggle. The poor's health statistics doesn't bother them at all, and many poor and working class whites have been convinced that these statistics are due to some innate flaw of the Black population themselves, not public policy. I want to use an example of talking about welfare. So up until 1996, we had welfare was aid to families with dependent children. It was a program that was not exactly like Medicare, but it was basically federally administered and federally funded. The monies, the federal government determined what the benefits were for families, and it had did have some variation for what different states should be based on their economic situation, but it was the federal government that said what families got. In 1996, Clinton got rid of AFDC and changed the program to a program called TANF, Temporary Assistance for the Needy Families. And the big difference in that program was that instead of a federal program overseeing how states gave benefits to the poor, it became a block grant program, sort of similar to like Medicaid, and states were given great leeway in what they did with the monies given to them by the federal government. Great leeway, great flexibility. And it was touted that this would be a way to improve and aid to the poor. Well, the Center on Budget and Policy Priorities in March 17th of 2023, in their report, pointed out that due to this broad flexibility that the states have had in using these monies, that it has actually caused extreme poverty to be worse in the United States. Many states have use that flexibility to divert funds away from helping the poor to other state budget priorities. In 2021, the monies that the federal government was giving to these states for poor families, only 1/5 of it was being spent on providing needed aid to needy families. The 4/5 of that money was going for other priorities. In 14 states, less than 10% of that funds was spent on providing care for needy families, on providing benefits for needy families. As a result, as I said, the level of deep poverty in the United States has increased. Fewer families that need money are getting it because the benefits are so, and I've already said the benefits are so low. And there's other problems. People haven't been able to get jobs that lift them out of poverty. So I can see a situation where with this change of these two bills, states will be diverting and using funds for other things, not necessarily health care. And they may set, and even though they're going to say that they'll set benefits that'll be appropriate and comparable to Medicare, to be honest with you, we've had trouble getting Biden's HSS CMMI to regulate Medicare Advantage and make them give decent benefits and not do all kinds of bad hanky-panky. What makes us think that if Biden gets reelected, he will really be interested in making sure that these bad states that have no interest in seeing that their populations, that their Black populations in particular, have adequate health care? What makes you think that he will really make sure that they are giving people adequate benefits? And if he doesn't win, if he does not win, my fear is that that SBU, HCA, and HR 6270 will be handing, if Trump gets in, will be handing Medicare's head on a platter to the right reactionary forces. What I want to say is we have to be careful in our struggle not to develop strategies that cause us to shoot ourselves in the foot. It's important in the struggle that no matter how difficult it becomes, we keep our eye on the prize of national single-payer health care. Okay, and that's just, I'm finished. I hope I made my point clear.
Much thanks to Kay and Claire for your excellent presentation of points in support of national single payer. As predicted, there are a lot of questions in the Q&A, and we're going to work to get through them. I'm going to consolidate some of them. I'm first going to decide to take us back to basics because there are a number of questions along the theme of, well, how are we going to get single payer? And, maybe the state implication is state would be easier, so we should abandon it. One person expressed it well this way: no national party seems interested in Medicare for all. The Democrats feel compelled to defend the ACA and the Republicans seek to nullify it. How can we change them? Research, statistics, and promised economic savings seem to matter little to them. Many in Congress are supported by the existing system, paying only lip service to Medicare for all advocates. Please offer suggestions on how to change this. And this goes along with some of the other questions that simply want to know how the heck are we ever going to get national single payer? So maybe I'll send that to Kay first.
How do you get national single payer? Well, I think first you have to decide that that's what you have to have. That if we would get a concentration of our efforts on that proposition, rather than for looking for other ways as proposing intermediary steps that we have to accomplish before we get there. I think we have to say to ourselves that nothing short of removing the for-profit insurance industry from our healthcare system is going to give us the care that we need. And then we should do a concentration on that. We should make the demand of Congress that they do more than just sign on to the bill. We should demand that they put on their website their support for this. We should demand that they speak in the 1-minute speeches and in the special orders in the Congress. They should demand that they put it on the agenda at their town hall meetings. We should demand that they do hearings, that they call all of the single payer experts from around the country to Washington to speak to the staff and the Congress. They should put it on the agenda as a serious program that has to be accomplished if we're going to have healthcare in our country, and many more things. I mean, we have to build the movement, but we first have to say that this is where the fight is, and we have to lay it on the doorstep of the Congress and insist that they take it on.
Yeah, and this is Claire. In addition to what Kay's doing, I think we have to buckle down and doing more, finding ways to do more outreach to regular folk, to help mobilize them. We need to be doing, if we're in unions, doing more talk to our fellow union members at churches. I know I've given talks at my churches. I'm on the advisory board of the Pittsburgh Black Workers Center, and I gave a talk to them, and I can tell you people are they want universal health care, but there's a lot of confusion about what Medicare for all means, what single payer means. So we need to be reaching out to people, talking more. I've done talks on radio shows. I know on California you have this, although it's geared more to the state base, but you have this, because I've listened to it, you have this little podcast, which is a good idea. I'm trying to do a podcast myself, but we need to have a strategy of doing more outreach and more mobilization to people, so that there's a greater force of people pushing Congress people to go in the right direction, to fight for Medicare for all. And that takes some work, and that's going to take some time, but there's no way around it. We have to do that mobilization in that building.
And I think, just in keeping with the answers that you both provided, there is a question that was posed, which is, please explain single payer. And I think we're obligated to explain what we mean by that. And I'm going to assume that we mean national single payer. But if that question is in the Q&A, I think we should form an answer, so that there's no misunderstanding about what national single payer is. I mean, I think our
Are you asking us to say what it is?
yes.
Okay.
And an explanation of how it gets there, what the funding is. I just want to make sure that people are clear.
Okay. It's a public, federally funded program in which everyone is covered. Healthcare is free at the point of service. There's no restrictions because it's sort of like Medicare. Every doctor is in it. No doctor is out. Every patient is in it. No patient is out. You go to the doctor or to the nurse practitioner or your therapist, you get your care, and then it's already been paid for, so you don't have to worry about any co-pays. You don't have to worry about any deductibles, because it's free at the point of service. And Kay, you can add whatever I left out.
Well, it's a little more complex than we can explain in a couple of sentences, but it's basically removing the profit-making industry from the control of the system and using public funding and public say-so over the system, making it responsible to democracy and to the people and to the patients, rather than to the insurance industry, which now determines everything about our system, from the high deductibles and co-pays and the expense of the system. It's caused by the profit-making industry, and it's a removal of private for-profit industry from the healthcare system so it can be a system that serves the people of the nation rather than the corporations.
And one thing I like to tell patients and also say to my fellow doctors, doctors complain because I can tell you as a doctor, the insurance companies micromanage what doctors do. I know I hear a lot of people being dissatisfied with doctors, but doctors are having to fight every single day. I have to fight with insurance companies on what I think is the best in the best interest of my patients. And they often they do not have, I can't say often, they do not have my patient's best interest at heart. They're trying to find the way to spend as least money as possible in addressing the patient's needs so that they can make profit for their CEOs and shareholders. And I have a lot of instances, I'd be here all night telling you, where what was in the best interest of the patient was overruled or not prioritized. Now, I fight a lot, but because, in fact, as a psychiatrist, I can tell you, they would like to see psychiatrists just be pill poppers. I call it pill poppers and paper pushers, instead of really trying to do some therapy or some work with kids and their families. And they make it very hard every single day. There's been a lot of literature lately about physician burnout. And one of the major causes physicians say is having to fight every day with insurance companies on giving your patient care.
So along the lines of fighting insurance companies, one question is, can the states actually ever be strong enough to fight the health insurance industry? Is it more feasible for us to do that at a national level? And either one of you can take that question.
Well, I think that, we've seen a number of states try to do referendums, and they get confronted, referendums on single payer, and they get confronted with an industry putting in much more money than the movement has. So indeed, it is a question, is how is one state ever going to be able to fight all the power of Humana, Aetna, Cigna, United Healthcare all on their own and actually be able to implement a single payer system that removes those insurance companies? We have a better ability to do that with all of us in it together and with everybody having a stake in what happens on a national level. Not that it's easy, but it's what has to be done. I can't see any state being able to do it. And one of the problems states face is they can't even get all the money into a single stream to do single payer. That's the reason why they're working to get this national law to turn over Medicare. But maybe that's where we should start, to say, at least we don't want to do that. We don't want to break up Medicare. And we could all oppose that bill and say that that would be a backward step for us.
And that's for the states that want to, but there are states that aren't even interested in fighting the insurance. There are states that on philosophy, they would rather support the insurance industries, unfortunately, because they don't see it. They don't even have the will to make that fight. And that's a problem for us. It's not like we have 50 states chafing at the bit to get rid of insurance companies. And if you look at the whole Medicaid situation right now, I think it's all but one or two states that Medicaid is really private insurance run, and the states they ran towards that. They didn't run away from it. They ran towards it. I think the only state that ran away from it, I think, was Connecticut, because they looked at there's a Commonwealth study a few years back that looked at, I guess all the states did studies looking at the response of privatizing their Medicaid. And it was clear from the studies that the quality of healthcare went down and the expense for the states of providing healthcare went up. And it's because of that that Connecticut decided to go back to just regular public Medicaid and kick out the private insurance companies. I'm not aware of any other state doing that. I think once they're in there entrenched like that, it's really hard for states to kick them out, to get rid of them.
So I'd like to address some of the questions about the Sabuka bill and the waivers that are included therein. So one questioner asked, would you support a state waiver bill that insisted on a single payer system and guaranteed no reduction in any federal rights and benefits? That is what the New York Health Act does.
I'm sorry, I don't.
Would you support a state waiver bill, I guess similar to Ro Khanna's bill, that insisted on a single payer system and guaranteed no reduction, that the state could not reduce any of the federal rights and benefits that are already insured through Medicare?
As a federal bill?
Yeah, I think it's a federal bill that would provide state waivers that insisted upon with upholding the values that are contained within Medicare.
Well, that's been discussed by some people. I guess that would be better. It still seems to me that it's the wrong direction. I don't think that a state is going to be able to enforce the same benefits under that people had under Medicare. And I think the idea of turning over money to the states rather than keeping healthcare as a federal responsibility is not a good direction. It would be better than turning it over to private companies, having them in the mix. But you see, let me just say this. When we have the ability to pass that kind of bill, giving money only to states that support single payer, we have the ability to pass national single payer. Yeah. Why would we do it the other way? And why don't we go with the national track instead of turning back to state action to do it?
And the other problem for me with that bill, if what the person's asking, it was a little confusing because of the way they put New York in there. But if they're asking if we had if the two federal bills had SBU HCA and HR 62070 did require states to implement a single payer program and had mechanisms to enforce them, making sure that the benefits were as in the federal bill. There are some states that would do that, but this is my problem. Would the black belt states even do that? Would they do like what's happened with Medicaid? They just refuse the money. Would they then say, okay, then we'll do single payer healthcare? I'm not convinced that, given the history, the racist history of those states, that they necessarily would.
Okay. A number of people along those lines are asking the question, should we discourage states who are close to obtaining a state single payer bill, such as California, with or without the Ro Khanna bill or the Sabuka language? Should we discourage them from continuing to fight for state bills that they feel they are close to securing one way or another? I think it's a philosophical question about how we strategize.
Let me just say one thing. I think that the work that everybody has been doing to teach about single payer healthcare has been helpful. And I don't want in any way to put aside the efforts that people have made. I learned from the people who are in PNHP who've been working on state and national bills. I just think it's time that we turn our attention to the national. It's over 30 years that states have been trying to do it and no one has accomplished it. And the barriers are greater than at the national level. So why would we work on that? I would encourage people to turn their attention to the national level effort as a more productive use of the movement's energy.
Yeah, I kind of agree with Kay on that. It's not a matter of discouraging people from their state struggles. It's more a matter of encouraging people to stay involved and ramp up the national struggle. Um, and as the problem for the what made us do these webinars, we saw that some things were happening that could seriously harm things on a national level, and those were those two bills. But for me, I'm pretty busy. I'm still working several jobs. I don't know how I get involved in all these movements, but I manage to. And if I have to, with the energy and time I have, if I have to look at where I want to put it, I want to put it on fighting for the national struggle. I can't do both. I can't fight on a state level and for a national level. And so to me, it seems like if we have to strategize on where we're going to put our energies, to me, it seems like we should be strategizing and putting it and building a national single payer bill.
I think something else sort of along those lines to think about is another question. Is there evidence that the system states would create would be anything better than what we have today?
Well, certainly under the way the bill is written, it wouldn't have to be better than what we have today. We would lose Medicare without making any gains in terms of health care.
Another questioner asked what would happen to the people who would lose Medicare in that sort of setup in the states. If state bills went to a different system and people lost some federal benefits, what would happen to those people?
What would a similar thing as to what happened with TANF? People would lose health care. People would be in poorer health. People would there would be more people that would possibly go bankrupt. I think if a state decided not to go, if the state decided to use its funds rather to help implement an entrenched privatization, I think you'd see a decrease in the quality of healthcare services, the access to healthcare, and all of that. But who would people care? That's the point. I mean, I think there's in certain states that people might have a concern. The states that don't have a concern, those same black belt states, they haven't cared that there's increased entrenched deeper poverty. Why would they care if there were more people who couldn't get access to health care?
Another questioner suggests, isn't it important to stress that multiple economic analyses have shown that a national universal single-payer health care system would save billions of dollars as well as lives, plus save gobs of time and worry for all? Republicans care about these things too. Since Biden said that he would veto such a bill, why not vote values, people, planet, and peace? Jill Stein, 2024.
Jill Stein here?
No, that was the questioner added that in there. I'm just reading the questions.
Okay.
I don't know if either of you would like to address it. I think it's sort of self-explanatory.
Yeah.
Fundamental. And another excellent question came from another questioner. How would single payer handle the VA? Would the VA be abolished or continue in the same or other form? What about entities like Kaiser?
Well, I think that I think the current single payer legislation in the House says that VA remains as a special program that has to be worked out over time, but it's not taking apart the VA system.
Yeah, the VA and the National Indian Service would stay. And there are many people that think that they're a better model even than single payer. Yeah, but that's what the current bills say. They keep them intact.
And what about entities like Kaiser? I think Kaiser's functions as a private corporation delivering healthcare. I think it would be the similar
It would
fate as many other forms.
that I think would need to be deprivatized.
Right.
That's right. No value-based care in the system.
Yeah.
Here's an interesting question. What would happen to snowbirds who live in 2 different states?
Well, we get a national plan, that's not a problem. It's perfectly portable. That's one of the problems that those who seek to do a state bill have trouble solving. It's how do they fix that problem? And I don't think it's fixable.
Yeah. Whereas a national single payer, you wouldn't have to worry what state you're in. Yeah.
Right.
And then the age-old question, how are we going to pay for it? This questioner writes, where will the funding for this federal program come from? Will it be added to federal taxes? Employers will still be required to input funds. Everyone will be required to pay some annual fee, perhaps, although maybe not too steep.
So luckily I was just reading something today. So first of all, you should know that there have been 13 studies that show that 80% of the population would actually be better off financially. Their healthcare costs would go. There would be some progressive increase in taxes. Some of the monies that we have in the private system would go into this public system. And then there would be a progressive tax. People, low-income people wouldn't pay any taxes at all towards it. Middle-income people would pay a small tax, but they would still be better off if you look at the small tax they pay versus what they pay now for their premiums and their deductibles and so on. They would actually have more money in their pocket, significantly more. And the only people that would who would find themselves paying more than they were in the past were that top 20%. Those people, yes, would be paying more, not a gigantic amount more, but would be paying more. So it would basically come from rolling money back from all, because right now, I think, and Kay, you can correct me, I think something like a third of the money we put into we're the most expensive healthcare system in the world. And yet we get less value for our dollar than all the other. Yes, someone said PNHP has developed a calculator, and I don't have it at the top of my head. Maybe that person does, but we're the most important and most expensive healthcare system in the world. And yet a fair amount, I think it might be as much as a third of our money goes to administration and stuff and paying these private corporations, making their insurance companies, making their profits and so on. So that would wipe out right there. And some money would be plowed back into the system. Some of that administrative money that was going to big insurance companies would now be available and freed up and go back into the system. But as I said, there would be a progressive tax increase. It would not affect 80% of the population would find that they were better off and had more money in their pockets.
Hey, did you have anything to add there?
Claire's right. I mean, basically single payer means that we stop paying premiums. We remove the insurance industry from our healthcare system, And rather than paying for our healthcare through those corporations that take 30% for profit and administration, we reclaim that money and use it for healthcare and invest it back into expanding it and covering everyone for dental and eyeglasses and long-term care, and doing away with copays and deductibles and setting up a system that we can use. The specifics of the taxing system are not in the bill as it is, so I don't know. I haven't yet looked at the calculator, but we could take a look at that. And I'm sure he had to, I think Jim Kahn did that, and I think he had to like posit a scheme for financing in order to work out the calculator. So, it's one model of how it might be paid for.
Yeah, and 13 studies. I read there were 13 studies looking at over a 10-year period, 10 years out. Looked at the system at the whole medical system. Would we save money or would we lose money by having a single payer? And a couple of these studies were done by institutions, think tanks hostile to single payer care. But even those one found we would strike even, but all the rest found that we would save a significant amount of money if we switched to single payer for the whole healthcare system of the United States, while providing better care for everyone.
And I'm seeing in the chat, multiple people have put the link to the chat, put the link to the calculator in the chat. So people should be able to see it there. It's also on the PNHP website, I know. Another question, would it not be possible to fight for incremental improvements in Medicare while we wait for a time when Medicare for All is feasible, specifically end Medicare Advantage, and use that money to improve Medicare, improving what it covers and who is covered?
Well, that's a fight that's going on now. Certainly that fight against the privatization of Medicare and against Medicare Advantage is a crucial fight, because it's pointing out the harms that are done by the private insurance industry. So it moves us forward. That debate and that discussion moves us forward. I don't know if it's possible to do away with Medicare Advantage and end the privatization without having the power to get Medicare for all. I don't know that that's so. I do not think we should substitute a lower demand for Medicare for all, because there is no solution short of that.
Yeah. I agree with Kay.
Sorry, one second here. I have another question specifically regarding why not supporting state bills. Another example of states doing good. This person wanted to say that when the federal government offered matching money for child health insurance, every state went along. And 40 states have expanded Medicaid under the ACA, including many deep red states. And this questioner has also asked what evidence is there that the federal government would ever take on health insurance companies. I know that's kind of a two-part question, but
well, that's a difficult question. Well, we had if Bernie Sanders had won, it seems he would have done it. I mean, and then there's the whole in terms of taking on progressive legislation that big industry doesn't like. We have the whole New Deal. Okay. So I'm saying it's not that we in terms of specifically the single payer fight, it's a type of fight where we won't know whether it can or cannot be done until it's done. When it's done, we'll look back and say, oh, of course, it could happen. but all these fights, I mean, the people who fought for slavery didn't know if they could overturn it till it was overturned, and for women's rights, I mean, these are fights that you can't say we should or shouldn't do them because we don't know if they can be done. I mean, history shows that usually if people are persistent in their efforts, in their fights, and do enough mobilization, that you do eventually win. But when you're going to win, you don't know.
You can't give up on your country.
Yeah.
You can't say it's okay to stay the way it is with so many
And
people
if we
dying.
yes, and if
we have to engage. We have to get in the mix, and we have to say that this is a viable issue. Nations have done it all around the world. What's wrong with us? Why can't we do it? Don't tell us we can't do it. Tell us how we can do it. Work with us to make it possible. We have to do it.
And if we don't fight, it's something like what, 17,000 people die every year unnecessarily? Is that the right figure? Or
Oh, I think it's
67,000 people
Yes.
are estimated to die every year.
very high. We lost about 300,000 in the pandemic that wouldn't have died had we had a universal healthcare system. We're 69th. I couldn't believe that Berwick 69th now in the world. Yeah. They're criminal figures. We have a criminal corporate entity hovering over our healthcare.
There are some third world countries. Yeah, there are some third world countries that have better healthcare statistics than we do, like Cuba. Cuba's this poor country that's being strangled by the US government, but it has some better health. It has a longer lifespan than the United States.
Our longevity rates are going down. We're now, I think, 4, 5, 6 years behind others. I think Japan's at 85, we're at maybe 78, 79. We have to look at this as a moral question as to whether we're going to fight to establish a humane system within our nation, or whether we're going to give up and walk away and look the other way. All of our lives are at stake here.
I'm going to address one more question. I think that's about all we have time for, and this one came towards the end, and it brings up some of the arguments that we have heard for advocates of state single payer. I'm going to try to consolidate it because it's a very long question. Basically, do you see value in state campaigns that allow advocates to educate and activate state legislators, our major source of future federal legislators? Do you see state-based efforts for universal health care similar to state-based movements such as the civil rights movement, women's suffrage, Social Security, the direct election of senators, the prohibition on indoor smoking, and gay marriage?
Well, I think that we can grant that the work that people have done has helped, but it's really time to move on, because staying stuck in the state mode gets us nowhere. We've been working on state single payer bills for over 3 decades. Kentucky introduced it in the 90s, very early 90s. No one has been able to do it. Let's take a look at putting it on a national basis and joining hands in the effort to place it on the national agenda. If we back away and say, well, it can't be done there, and that's what people say, but we have to work in the state because we can't do it in Congress. And I'm asking that the movement look at that again and say, if it needs to be done on a national level, then we have to place it on that agenda and figure out how to make it possible. If it's not possible now, what must we do to make that possible? And we should ask our Congress that as well, because they're the ones in position to do it.
Claire, I'm going to give you the last word.
Oh, okay. Well, I think there's some value to fighting on a local and state level to get some kind of referendum through saying this is what we want and this is what we need, sort of like what was done in Dunn County and things like that. I think that's certainly a valuable effort. Looking at my own state, and it is so reactionary. We have a few state legislatures that have tried to get something in the legislature. In our state, we have a better chance of getting national than way better chance. But I think that if we can galvanize all of our politicians to say this is what we need federally, this is what we need nationally, we need to just get on the job of moving forward with it. I think that would be the best thing of all.
Well, thank you both for your excellent analysis of this very difficult question as to how do we get national single payer? How do we support each other in this movement? And I think everybody in attendance has had a great experience in understanding the issues a little bit better. I'd like to pass the wrap up now to Ed Gristar. Go ahead, Ed.
Okay, thank you. And I just want to congratulate both Kay and Claire for actually performing what I think is a very essential task. We have to shape this national agenda. We have to recreate the idea that what is possible, it's not only possible, but it's totally necessary. And the concept that we somehow cannot achieve this has to be stricken from people's consciousness. We have a majority of the population that is supportive of us. Yet there seems to be this despair in many of the people that somehow we can't achieve it. We are working in national single payer, and we encourage you to support our work. We want to build a movement, a real movement, not a campaign, not a political campaign that is turned on and turned off. We don't want to work the inside game with politicians and worry whether we have access to them. We're looking to build strength through people power, and we can achieve that. Look at history. Everything that we've done in history that has really made a difference has been through that mechanism. People are sometimes afraid of that. They think that that is not the way to go. Well, that's why we together are working with national single payer. So we encourage you to support our work. Please donate to us. We have the links in the chats. You can go to our website, www.nationalsinglepayer.com, to sign up for our email and our monthly newsletters, where you'll find registration links and all of the articles and webinars that we have done. Join us on Wednesday, May 22nd, 5 p.m. Pacific, 8 Eastern, for our working group session. If you want to have more conversations on these issues, how you can set up a local group, we're interested in discussing and debating in an honest fashion about what needs to be done. And we do think that it is possible. Many of us have been working on this for our whole lives, and we know many of the people in this participants are in the same. So please consider joining us. Save the date on June 12th for our NSP primer on reproductive justice. That will be our next webinar. And stay tuned on our website and our information for our updates on national single payer campaigns that we will be hoping to push in the weeks ahead. So with that, again, thanks, Kay. Thanks, Claire. Thank all the participants, and we hope this was informative, and we wish to continue this in the future.
Okay.
Thank you all for coming, and good night.